Today's lecture content includes complications related to infusion therapy, as well as the interventions to take to treat these complications. Let's begin by discussing the different types of localized complications, including ecchymosis or hematoma, infiltration, extravasation, phlebitis, post-infusion phlebitis, thrombosis, thrombophlebitis, and phlebothrombosis. Then we'll discuss some of the systemic complications of infusion therapy. By definition, a localized complication involves the tissue at or near the actual catheter insertion site or the exit site. This typically occurs because of trauma or damage to the vessel wall. Now, these types of complications are easily treatable and cause no long-term effects or serious issues. The key, though, is to identify and initiate treatment quickly. For the most part, these types of issues are caused by a mechanical failure, such as puncture of the vessel wall with the IV catheter. Subsequently, once the mechanical failure is addressed, i.e. the catheter is removed and pressure is applied to the site, the symptoms resolve. Ecchymosis or hematoma are probably two of the most common complications and easiest to treat. Basically, an ecchymosis or bruise is caused by the leakage of blood into the tissue surrounding the IV site. A hematoma also results from bleeding at the site, but the bleeding is uncontrolled and ends up causing a hard and painful lump. Either of these can be caused by using the same vein multiple times or when an unskilled person tries to insert an IV catheter. Treatment includes removal of the venous device and applying pressure to the site, i.e. a pressure dressing. Depending on the extent of the injury, a dressing may be required, especially if a hematoma develops because the insertion site may continue to leak as the hematoma resolves. Once treated, the site should be monitored and reassessed. Infiltration is the leakage and/or accumulation of fluid into the tissues surrounding the IV site, causing pain and swelling. Depending on the type of IV solution that has leaked, the patient may encounter blisters, sores, peeling skin, or even necrosis. Treatment for infiltration includes stopping the infusion, applying warm, moist compress to the site, documentation, reassessment, and lastly, obtaining a new IV access. Extravasation is a form of infiltration in which the medication that has infiltrated damages the tissue to the point of causing necrosis or severe damage. This is called a vesicant and includes solutions such as chemotherapeutic agents. In the incidence of extravasation, the nurse would notice obvious tissue destruction, blistering, tissue sloughing, pain, loss of mobility in the affected limb, and even infection. Patients may also experience pain along the vein. The number one goal is to prevent extravasation altogether. However, when it does occur, treatment includes stopping the infusion immediately, aspirating the contents through the needle that is still intact, elevation of the extremity, use of warm compresses initially and then cold later. We should also initiate new IV access. Notice that I didn't say to remove the cannula in which the extravasation occurs. I did not mention this because this is a facility-specific treatment, as sometimes the cannula is left in place in order to administer treatment through the catheter. Finally, do not manually compress the extravasation site, as this may worsen the extent of the damage. Phlebitis is another complication and is the inflammation of the endothelial cells of the intima of the vein, which is the innermost lining of the vein, which has contact with the solution being infused. As a result of the inflammation, the normally smooth cell wall becomes rough and platelets begin to aggregate at the cell wall. Phlebitis is characterized by pain and tenderness along the vein, redness, swelling, and warmth at the site. Several factors can affect the development of phlebitis, including the length of the infusion, the type of solution being infused, the location of the infusion site, the technique used to insert the cannula, and the method used for cleaning the skin during insertion. Phlebitis is one of the most common types of complications reported among people receiving infusions. As a result, a 0 to 4 phlebitis rating scale was developed to help practitioners document subjectively. Grade 1 means there is redness at the site but no associated pain. Grade 2 means that the patient is reporting pain in addition to redness and/or swelling at the site. Grade 3 indicates pain, redness and swelling, or streak formation, as well as a palpable venous cord. Grade 4 includes all of these symptoms found in Grade 3. However, the venous cord is measured greater than 1 inch in length, and there is purulent drainage associated with the phlebitis. There's also a visual infusion phlebitis score, and this is on page 208 of the textbook, and you can look at this score. On the visual infusion phlebitis score, each score has an associated treatment listed beside it. Treatment depends on the severity and can range from mild to moderate phlebitis, which will resolve on its own, or in the case of severe, i.e. a rating of a score greater than 2, the infusion will need to be stopped, the IV cannula removed, elevation of the limb, and administration of anti-inflammatory creams, gels, or oral anti-inflammatory analgesics should be administered. Now moving on to post-infusion phlebitis, which is the occurrence of phlebitis within 48 hours to 96 hours after the cannula has been removed or after the administration of the infusion has been completed. Several factors can contribute to the occurrence of this type of phlebitis, including a poorly inserted cannula, a patient that's very debilitated or having poor veins, the infusion of hypertonic or acidic solutions, use of a large gauge cannula in a small vessel, or failure to maintain adequate hygiene in relation to the IV site, such as failure to change IV tubings, dressings, caps, or the cannula itself. Thrombophlebitis is exactly as it sounds, the occurrence of phlebitis with the addition of a thrombus or blood clot as a result of the injury to the vessel wall. This is a more serious condition as it does involve a blood clot, which we know can become a more serious problem if the clot dislodges and becomes an embolism. Symptoms of thrombophlebitis include pain, redness, and swelling, just as with phlebitis. However, the longer the catheter remains in place, the worse the symptoms occur until the entire length of the vein is involved. As a result, circulation is obstructed and the vein becomes hard, tortuous, and very painful. This may be indicated by slowing or stopping of the infusion. The patient may suffer from the condition indefinitely or may suffer from an embolism. If the thrombophlebitis is superficial, typically removing the IV and applying heat will improve the symptoms. Prevention is ideal and can be accomplished by avoiding the use of veins in the lower extremities, selecting an appropriate vein, avoiding veins in movable parts of the body such as in the bend of the arm, and securely anchoring the catheter prior to infusion. Phlebothrombitis indicates the development of a blood clot in the vein without the presence of phlebitis. This type of condition places the patient at a greater risk of embolism because the clot is typically unstable and the symptoms associated with phlebitis that would normally indicate that there was a problem are absent. The difference between the two is obvious in the pictures provided here. There are also several systemic complications that we need to discuss, including septicemia, pulmonary embolism, air embolism, catheter embolism, pulmonary edema, allergic reaction, and catheter-associated infections. Systemic complications are more serious than localized complications. Septicemia refers to the invasion of the bloodstream by bacteria or other microorganisms. Symptoms of this include fever, chills, malaise, and headache. Treatment for septicemia depends on the severity and may include fluid resuscitation, vasoactive support, oxygen therapy, nutritional support, and maintenance of acid-base balance. Also indicated is the use of antibiotics to treat the infection and steroids to reduce the body's response to the infection process. It is important to keep in mind that any type of IV access is a potential portal of entry for microscopic organisms or disease-causing agents and must be treated and maintained to the highest degree. CLABSI is an excellent example of how serious septicemia can be, not only for the patient, but also as it relates to quality of care and reimbursement. Next, we'll talk about pulmonary, air, and catheter embolism. As we know, an embolism is defined as an obstruction of an artery caused by a variety of methods as previously indicated. Specifically, a pulmonary embolism occurs when one or more arteries within the lungs are blocked by a blood clot. An air embolism is a blockage of the blood supply caused by air pockets or bubbles in one of the cardiac vessels. A catheter embolism can result of a piece or particle of the catheter itself breaking loose and blocking blood flow, or can occur when an aggregate of platelets and fibrin forms on the tip of the catheter and breaks loose, impeding blood flow as well. All three of these conditions can be life-threatening and require immediate and aggressive treatment. Symptoms associated with pulmonary embolism include shortness of breath, chest pain, cough, lightheadedness, rapid heart rate or palpitations, rapid respiratory rate, or respiratory failure. Likewise, an air embolism presents with the patient experiencing acute shortness of breath, continual cough, gasping, dizziness, nausea, substernal chest pain, agitation, disorientation, or fear of impending doom. Pulmonary edema can also occur as a result of infusion therapy and results from an overload to the patient's circulatory system, in which the excess fluid ultimately backs up into the lung tissue. Symptoms include increased PVD, hypertension, rapid respiration, and shortness of breath. Treatment is required as soon as possible to reverse the edema and includes slowing the rate of infusion and notification of the provider. The patient should also be placed into the sitting position to make breathing easier. Here again, preventative measures are the ideal way to manage pulmonary edema. I'm not going to go into a lot of detail in regards to allergic reactions simply because the signs and symptoms and treatments and the effects of allergic reaction are the same with any type of medication or method of medication administration. I do want you to keep in mind that if an allergic reaction is suspected, the infusion should be stopped immediately and the patient should be monitored for signs and symptoms of anaphylaxis. Ultimately, prevention, identification, treatment, and reporting of systemic complications are essential for positive outcomes for our patients. There are a couple of rare complications that I want you to read about on your own, and those are reflex sympathetic dystrophy and complex regional pain syndrome, and those can be found in the textbook.